Hey you guys, it's Dr. BT, and I just want to talk to you about this Menti we did. I know that some of you had asked for it, and I wanted to talk to you about how to use it. So the first thing, I didn't want to put it in a PowerPoint because sometimes I think you just like to listen. So I just recorded this, and you can do what you want to with it. Make sure you use the nursing process, ADPI, assessment, diagnosis, planning, intervention, and evaluation. Whenever you are assessing, use Maslow's hierarchy of needs, which we talked about: breathing, food, water, sex, safety, and homeostasis and excretion. Then the next one is safety. And so a lot of the questions on the NCLEX is, how do you either ensure somebody is safe? How do you prevent injury? Or in a negative way, how is this a risk for injury? So either answer the question based on the physiologic things, and then of course look at safety things, because most are safety. Triage, so whenever you're trying to put things in order and who to see first, second, third, acute and then chronic, emergent versus impending. Assess always before you intervene, and of course never leave the client. So here are questions. The nurse is preparing for a 24-hour discharge. While doing the teaching, what intervention is most important? Ensuring, and the answer is evaluate if the infant feeding techniques are okay before you discharge them. You have to make sure that this baby is pooping and peeing and doesn't have abnormal vital signs, has a follow-up appointment at the pediatrician's office the next day, and you got to make sure that mom is not bleeding excessively, saturating the pad in 1 to 2 hours, is not hemorrhaging, of course, and is afebrile as well. So you got to make sure of all those things before you can do an early discharge teaching. The Ballard score determines that a 15-minute-old infant is 42 weeks old. So you get a baby out, probably a drop-in. You can see that the baby is super old. Which intervention is most important? Giving oxygen, drawing blood gases, applying a pulse ox, or obtaining a blood glucose. Of course, obtaining a blood glucose, because the blood glucose is most important, because this baby can be really big, this baby can be really skinny, but we do know we have an old placenta that may not have been functioning well and giving the baby the amount of oxygen and nutrients that we need. So the blood glucose is super important. Next, a 16-year-old girl, G1P0, has been admitted with eclampsia. She is not presently convulsing. So she came in with seizures. Obviously, she went through preeclampsia, and now she's had a convulsion. Which intervention should be included in her care plan? And we have to remember that babies don't get oxygen when the mom is actively seizing. So they may have to intubate her. So assess the temperature every hour. Monitor the vital signs every 4 hours. Allow liberal family visitation, or keep an airway at the bedside. It's keep an airway at the bedside, just in case anesthesia comes and has to intubate her. A 38-week patient is receiving mag sulfate for severe preeclampsia. What assessment warrants immediate intervention? So let's just talk about magnesium sulfate for a second. Magnesium sulfate is a drug that relaxes the central nervous system and prevents moms from seizing. It also is a protectant for babies under 32 weeks for cerebral palsy. So we love mag sulfate, but it's a very, very dangerous drug. So you have to do several assessments. You have to, every 1 to 4 hours, you have to check their alertness and orientation. Because they could get too much and become snowed. They can go into a coma. Check their blood pressure. You don't want their blood pressure to bottom out. If they're pregnant and their blood pressure is low, it could cause uteroplacental insufficiency, of course. You want to check their urine output. You want to check their DTRs to make sure that they don't have absent DTRs, which is a sign of toxicity. So alert and orientation, respiration, of course, fetal monitoring, DTRs, and urine output. So if they have absent DTRs, we're in a lot of trouble. Lower back pain is usually a sign of preterm labor, but this patient is 38 weeks, so that would not be applicable. Dizziness when standing, sinus tachycardia are not the answer. And again, absent patellar reflexes. Excuse me. Remember that the antidote is calcium gluconate for magnesium sulfate. Patient 39 weeks presents to the ER after a fall with an injury to her arm. You guys, anytime a pregnant woman falls, we have to put them on the monitor for 4 hours because they can have an abruption. It's super serious. Any falls, safety-wise, like we have to make sure that this baby is okay. Even though we may not see any major things on the mom, we got to make sure that she did not hit her abdomen and cause an abruption, a concealed abruption, a partial abruption, anything like that. What concurrent symptoms is a priority? So, bruising on her knees, +1 pedal edema, normal. And we would expect ecchymosis on her knees because she fell. Pain in her forearm, well, that's what she came in for. But dripping urine could be broken amniotic fluid. And of course, we don't want that. There are 3 ways of knowing if it's amniotic fluid or urine. 1, we do a pH, and if it turns dark blue, it's amniotic fluid. 2, we can take the amniotic fluid, put it on a slide, and look for ferning. And then 3, we can send an amnisure, which is a little swab that we send to the lab that gets a definitive diagnostic on it that tells us yes or no if it's amniotic fluid. A neonate has been born with spina bifida. Which of the following have the greatest impact on the development of the neonate? Preeclampsia, no. Tobacco use, no. Might make the baby small, but doesn't have anything to do with spina bifida. And short intervals between pregnancy doesn't have anything to do with it. It's all about folic acid deficiency. So you guys, we want people to be on a prenatal vitamin before getting pregnant to make sure they have enough folic acid in that first little bit so that it will protect the baby. But folic acid is the big one here. A new patient presents to the clinic. Her period was 2.5 months ago, which is 10 weeks. She complains of severe nausea, brownish bleeding. Her vital signs are 98.7. Respirations are 18. Her BP, see if I can get it to come up. Well, on here, it's not coming up. It's not showing me. But her BP is, here, let me pull it over for you. Let's see if I can pull it over. Her BP is 190/110. Based on this assessment, which labs should the nurse review? So you guys, there's a lot of information here. So 10 weeks ago, she's already preeclamptic, severe preeclamptic. Her BP is 190/110. So we know we got a whole lot going on. She's nauseous and she's bleeding. So you guys, this is indicative of a molar pregnancy. And we know that a molar pregnancy is just, there's no baby, there's no fetus. It's just clusters of placental tissue that have grown like crazy. And the reason why there's placental tissue is because the chromosomes were not correct to make a baby, but it was enough to make a placenta. So with molar pregnancy, the big thing is to have a D&C, have all the vesicles or the overgrown placenta removed. We have to follow up with them and make sure that they come in every week to make sure that the HCG is going down to nothing. If it goes back up, they need to go on chemotherapy because molar pregnancies can cause it's called choriocarcinoma, or it's a metastatic cancer that could actually kill her. So it requires close follow-up. It's very difficult for the patient, and it is a long recovery period. An active labor patient of 8 hours is dilated 3 centimeters. The external fetal monitor is consistent with hypotonic labor. So that means that the contractions are not coming close enough to really do the job we need to in labor. If she's going out of the labor curve, it's too slow. The contractions are less than we desire. We desire contractions every 3 to 5 minutes lasting 45 to 90 seconds. She's prescribed oxytocin. So, of course, anytime any mom is on any medicine, it's continuous fetal monitoring. So we're going to watch that. We're not going to prepare for a C-section. We don't really need to do the client's hourly BP, which we would, but it really has nothing to do with the oxytocin. Check for a bulging perineum. That would tell us that the delivery was imminent. But when someone is on oxytocin, we're going to monitor the intensity, interval, and the length of the contractions. If it's too much, we turn it off, let the receptors reset. We can turn it on 30 minutes to an hour later and restart the infusion. But it's a very dangerous drug. Also, remember the oxytocin, the side effects of oxytocin are fluid retention. So you may have a patient who's been on oxytocin therapy and they're super swollen after delivery, and that's just simply because of the fluid retention. Also remember that if you use oxytocin as a supplement to labor or an induction agent, they run the risk of postpartum hemorrhage because the uterus worked harder than necessary, or than it wanted to, I should say. And so they're at risk for postpartum hemorrhage. A new mother is breastfeeding her 4-week-old and has type 1 diabetes. She reports that her insulin needs have decreased since she gave birth. This is her teaching. So obviously you guys know that if you're a type 1 diabetic, HPL or HCS is going to make your insulin needs go up during pregnancy. As soon as your placenta falls out, you're going to go back down to what you were before you got pregnant. You're still going to have insulin needs if you're a type 1. If you had no diabetes prior to getting pregnant, you just have gestational diabetes, then you should go back to the normal status that you were. So what are we going to teach her? Advise her to decrease her calories? Absolutely not. She's going to need to take in 500 extra kilocalories a day while she's breastfeeding, because she's actually doing a metabolic process and making milk. Just as a caveat, when anyone is pregnant, we tell them to increase their calories 330 a day to get the extra nutrients for the baby. Advise the patient to breastfeed more frequently. Now, every 2 to 3 hours is really what we need. Schedule an appointment with a diabetic nurse educator. Nope, because it is normal that her needs have decreased. Inform her that her insulin needs decrease while breastfeeding. Absolutely, because she's working. She's making milk. A client at 18 weeks gestation was informed this morning that she has an elevated AFP. We know that the alpha-fetoprotein is a lab that's drawn at 15 to 20 weeks. It is only a screening test for Down syndrome and spina bifida. If it is elevated, there's a risk for spina bifida. If it is decreased, there is a risk for Down syndrome. After the health care provider leaves, what are we going to tell her? Tell her it will be okay. We never tell people that. Ask her to leave a urine culture. Urine doesn't have anything to do with her alpha-fetoprotein level. Explain to her she must have an amniocentesis. If it were decreased and she was at risk for Down syndrome, we would tell her that if she wanted a more complete diagnostic picture, she can have an amniocentesis. We don't ever tell someone they must have additional testing, especially when we talk about amniocentesis, because there are so many risks. The risk with amniocentesis for the mom is bleeding, infection, injury, loss of the fetus. The fetal risk for amniocentesis are injury. We can stick the needle. We can cause an abruption, infection, bleeding, all of those. But what we would tell this mom, if she had an elevated AFP, is that a sonogram, if they schedule a sonogram, it's non-invasive, won't hurt the baby. It can be scheduled for definitive results so they can actually see it on sonogram. Newborn's head circumference is 12 inches and his chest is 13. What we do know is that the head should be 2 centimeters greater than the chest. So we can already see that the head is 2.5 centimeters smaller than the chest, and there is no molding. So you guys, molding can skew this picture a little bit, but this kid is not molded. This kid was born by a C-section, and he's got a head that is smaller than his chest. We definitely worry about microcephaly. So what action should the nurse take? No action is needed. C-sections have a smaller head. This is the opposite. C-sections, their head is what it is. There is no molding. We have a good diagnostic picture or screening picture. Identify the neo immediately due to suspicion of hydrocephalus. No, this head would be bigger. Record the finding as normal. No, that's not the correct answer because this is not normal. Notify the neo or ped as the head and chest circumference ratio is abnormal. A laboring patient has variable decelerations, UV and W shape. What actions should the nurse take? Assess for cervical dilation. No, that doesn't really have a lot to do with the variables unless it was when the water broke. If the water broke and we had variable decelerations, we would worry about a prolapse cord. But this says nothing about that the water has broken during this period. Administer oxygen via face mask or turn off the Pitocin infusion. Nope, change the client's position. So change the client's position is what we always do with variable decelerations. A neonate is experiencing cold stress and is placed under a radiant warmer. What intervention ensures safety? So the rules for putting a baby under a neonatal warmer mean that you have to keep the baby safe. It can't get too hot or too cold. How do you do that? You put the little temperature probe on the belly, on the liver, on an organ, and the liver, the right upper quadrant in the abdomen is the best place to put it because it will give us a core temperature. So we can see these answers are wrong. Wrap the baby in 2 blankets and place the warmer on low. Dry the newborn's scalp and put a cap on its head. You would dry the newborn's scalp, but you don't put a cap on its head. They have no clothes on under this warmer because they can get too hot. Move the temperature probe over the ribs. And put them in a sideline position. Nope, you don't put them in a sideline position ever. You always put them on their back for SIDS prevention. And if you put it over his ribs, you're going to get a different temperature. When you put it over an organ, you're going to get a deeper temperature, a more core temperature. When you just put it over his ribs, you're just going to get a skin temperature. So the correct answer is to ensure safety, to prevent this baby from getting burned or too hot or too cold. Place the temperature probe on the abdomen while using the radiant heat source. A 6-week gestation, at 6 weeks gestation, a mother's rubella is not immune. So this is risky. We know that rubella is one of the torch that can cause the baby to have problems, hearing problems, brain growth problems, a lot of issues. So this is troublesome. We have to do a lot of teaching to prevent her from getting rubella during the pregnancy that could be a tragedy to the fetus. When should the rubella immunization be provided to this client? So now, when do we immunize her? Immediately? No, it's a teratogen. It's an attenuated live virus. So no, we're not going to give it to her immediately. We're not going to give it to her at 20 weeks because it's a teratogen. After the client stops breastfeeding, so you guys, the breastfeeding really has nothing to do with it because the baby gets passive immunity and the mom cannot transmit rubella to a baby through breastfeeding. And besides, mom doesn't have rubella. She only has a vaccination and she makes IgG and IgM. So when are we going to give the mom rubella? Early postpartum, within 72 hours after delivery, as she's walking out of the door. As a caveat, we also give, if someone needs a Rhogam shot, they have to give it within 72 hours after delivery. Woman's trying to get pregnant. She's upset that her pregnancy test was a false positive. Which information provides the greatest degree of accuracy? So this question is really asking you about probable, presumptive, and positive pregnancy signs. Probable, I missed my period, my boobs hurt, and I'm tired. That's probable. That's the least accurate. Moderate accuracy is a positive HCG, positive Chadwick sign, softening of the cervix, and softening of the uterine isthmus. Good positive Goodell sign. So you guys, that doesn't tell us for sure you're pregnant. The only thing that tells us for sure you're pregnant is seeing the baby, palpating the baby's fetal movement, or hearing another heart rate that is different than the mother's. So this one is asking us the highest degree, or which is positive. So completes of feeling tired all the time? No, not the answer. That is probable. Maternal blood positive for alpha fetal protein? No, that is probable. Presence of amenorrhea for 2 months? No, that is presumptive. Or visualization of the embryo by vaginal ultrasound? That is positive. A nurse is planning the discharge for 4 mothers, which is at the highest priority of having psychological difficulties during the postpartum period. HESI is very big right now on support for the significant other. While reviewing information, I keep seeing it over and over and over, support, support, support. So this question is not really referring to depression, but it's really referring to support. So the answers are a multiparous client who lives with her husbands and her family members. Well, she has lots of support. She's had a baby before, she lives with her husband, and she has family to support her. A multiparous female with a large family living in a community. Obviously, same kind of situation. It doesn't say that she has a significant other or a husband, but she has a large family. So those are there to support her. A primiparous adolescent living at home with her parents and her significant other. Has a lot of support, significant other and her parents. The one that stands out is a primiparous woman who has recently immigrated to the U.S. with her spouse. So she doesn't have family and all she has is her spouse. So she would be the highest. A 35-week client complains of pain when the baby moves. So her uterus hurts when the baby is moving. So her uterus hurts. Pain, her temp is 101.2 and the uterus is tender on palpation. So when we do our Leopold's, it hurts her, which is telling us her uterus is tender. We're like thinking, is it an abruption? But we clearly see that the temperature is 101.2. That makes us worry about her uterus being infected. What do these findings suggest? Round ligament pain? No, those are in the bottom of the pelvis and they're usually unilateral. Viral infection? Could be, but it's not on the, it doesn't really, it's not one of the big ones that cause uterine pain during pregnancy. Abruptio could be abruption, but the best answer is chorioamnionitis because we know there's inflammation markers when there's an infection. So usually the white count goes up. There's pain with any infection usually. And she has a temperature. So the correct answer is chorioamnionitis. And we do know with chorioamnionitis, the big offenders are the ones that cause disease most are gonorrhea, chlamydia, and E. coli. A primipara has delivered a stillborn fetus at 30 weeks gestation. Can't even begin to imagine how bad this would feel. To assess the grieving process, which intervention is most important for the nurse? So now we need to give an intervention and then assess how the patients are doing with it. So take the baby immediately to the nursery for assessment? No, that's not going to tell us anything about how they're grieving. Start the funeral planning as soon as possible? No, again, we're not assessing anything. We're just doing something there. Do not allow the neonate to stay in the room? No, that has nothing to do with, looking at this family and see how they're doing with grieving. But provide an opportunity for the parents to hold their neonate in privacy. We can do that, and then afterwards we can see how well they are doing with the grieving process. What is the most important assessment for the nurse to conduct following the administration of an epidural anesthesia to a client who has 40 weeks gestation? So what we know is the biggest risk during epidural anesthesia is maternal hypotension, which can lead to uteroplacental insufficiency or late decelerations. What we do is we preload the baby, the mama, with 1 to 2 liters of fluid because we know that hypotension is a huge risk. So we give her 1 to 2 liters of fluid prior to the epidural. And then, of course, any time that mom has any meds, any procedures, we have continuous fetal monitoring. So we monitor the baby. And then we watch the blood pressure a lot. Like we take it every 15 minutes for the first couple of hours, and then we take it every 30 minutes as long as we know it's stable. So the maternal blood pressure is the correct answer. Level of pain sensation, that would be evaluating pain, which is important, but the blood pressure is the physiologic part that is more important to the mom and the baby. Station of the presenting part and variability of the fetal heart rate. None of those are near as important as the maternal blood pressure. The care plan for a patient with a 30-week gestation who is experiencing preterm labor include. So you guys, when people come in with preterm labor, of course, we give them 1 dose sometimes of breathine or terbutaline, and we get them on MAG. And then the biggest thing is getting the steroids in, and before 34 weeks, we get in 2 doses of steroids, betamethasone or dexamethasone, to help with fetal lung surfactant. So the answer is the betamethasone. Stadol, of course, the teaching there is, or what's important there is, with Stadol, you can't give it to them within 1 hour of delivery. Any IV narcotic, because we don't want the baby to come out with respiratory depression. So this is just talking about a care plan for a preterm labor, not a delivery patient. So that's what this Stadol. Ampicillin is for GBS, obviously. We want to give anybody who is GBS positive or unknown ampicillin. It needs to be in the system for at least 4 hours before delivery. And then there's your breathine, Tribulene, which is a good answer, but we're not going to give it ×3. The nurse is caring for a female client, a prima gravida with preeclampsia. The findings are 2+ proteinuria, which is half of our diagnostic criteria. We know our diagnostic criteria is 140/90 on 2 separate occasions, or 160/110 on 1 occasion, plus proteinuria, visual disturbances, alterations in labs for liver, alterations in labs for kidney, BUN, creatinine. So she is full-blown severe preeclampsia. She's got 2+ proteinuria, blood pressure is 172/112, facial and hand swelling, and let me pull over here. Complains of very blurry vision, severe frontal headache. Which medication should the nurse anticipate for this client? Of course, mag sulfate. We're just trying to prevent her from having a seizure. We want her to get her settled out, and then we will go from there. Postpartum client who is RH negative refuses to receive Rhogam after delivery of an infant, or I should say neonate. Sorry, Hesse, you should not say infant, who is RH positive. So, what information should the nurse provide this client? Rhogam prevents maternal antibody formation for future RH positive babies. That's what we need to tell her. That's the most important part. These answers are not correct. Rhogam is not necessary unless all her pregnancies are RH positive. So that's like a half-truth. Like, Rhogam is necessary during pregnancy when we don't know what the fetus is going to be. But if the baby's RH positive, yes, they need the Rhogam shot. The RH positive factor from the fetus threatens her blood cells. No, they don't threaten her. They threaten the offspring, the next baby. The mother should receive Rhogam when the baby is RH negative, and we know that is incorrect. The baby has to be RH positive. A full-term neonate, 24-hour neonate is in the nursery. It regurgitates and suddenly turns cyanotic. So look, dudes, it says the baby throws up. I know you want to grab a bulb suction. So do I. I do want to suction the mouth and the nose first, but it doesn't say that the baby still has fluid in its mouth and nose. But it does say that it turns blue. Okay, so you have a blue baby. It threw up and now it's blue. We need it to take a deep breath and cry to get it to pink back up. So if it said there was fluid in the mouth and nose, we would suction the mouth first, then the nose. Give oxygen by positive pressure? No, let's just do the first available intervention that we know is going to clean it up, or is going to improve the situation, which is rubbing the baby's back, causing it to cry, taking a deep breath, closing that foramen ovale, and making the baby ping back up. A term client's water broke at home. She's in active labor at 7 centimeters, so she's about to deliver soon. What information is most important for the nurse to obtain first? Of course, we want to know the time. We're worried about this baby being infected. Greater than 24 hours is infection. 18 to 24 hours is a high risk for infection. So time would be second. Number 1 would be color and consistency, because we know if there's meconium staining, if it's green, brown, chunky, whatever, we know that we need to have Neo there. She's 7 centimeters. This baby may not be able to breathe when it comes out because of the meconium staining. So number 1 is color and consistency. Amount noter would be 3 and 4. A 1-day-old neonate develops a supple hematoma. So we know we have an injury to one side of the head, which is abnormal. Caput succedaneum is completely normal. It's just fluid across the whole head, which is dependent edema. But again, a cephalohematoma is a rupture of vessels underneath the skin and the scalp, and we have some red blood cells that are going to start lysing. The nurse should closely monitor and assess the neonate for which of the common complications. Hypoglycemia, no, has nothing to do with the cephalohematoma. Brain damage, I mean, yeah, could be, but how are we going to assess brain damage? We can't. Poor appetite usually doesn't have anything to do with the cephalohematoma, but we know jaundice does. We know that whenever there are extra red blood cells that are lysing from RH incompatibility, ABO incompatibility, an injury, bruising, ingestion of blood from the baby, if the baby swallows some of the blood during delivery, all those red blood cells lyse. In order to get rid of the bilirubin that happened after the red, so when the cell lyses open, it releases heme or iron and globin. The globin has the bilirubin in it. And so the bilirubin, whenever there's lysis of a cell, is unconjugated. It has to go to the liver and get conjugated so it can be excreted out. If there's any extra blood, or like this cephalohematoma, there's extra red blood cells that need processing, or extra bilirubin that needs processing from unconjugated to conjugated. So we know that the baby does not use its liver in utero, so we know it can get backed up, and we know that the bilirubin level, the bilirubin level can elevate. We never want the bilirubin level to get to 21 milligrams per deciliter. That can cause kernicterus or brain encephalopathy, which is irreversible brain damage. So we see this cephalohematoma, we watch for jaundice. I apologize. Obviously, our first intervention is to feed this baby, because the more they pee, the more they poop, the more bilirubin slides out the chute. Then we can do our physical assessments, looking for yellow coloring, starting at their head, going down on their skin, looking at their sclera. We can do a transcutaneous bilirubin evaluation, which is not invasive. We just take the little probe, take a picture of the skin 3 times, let it measure how much bilirubin is trapped under the skin. If it's more than 5 milligrams per deciliter in 24 hours, we know we're at serious risk. So we do all of those things. If we have an elevated bilirubin, like if it's greater on the screening, we're going to do a blood stick, send it down, and we're going to get back a total bilirubin, an unconjugated, and a conjugated. So the total bilirubin is just the unconjugated plus the conjugated. That's all. So for us, we're hoping that we have a good prognosis. A good prognosis would be more conjugated and less unconjugated. So if we have a total bilirubin, let's say of 7, and 5 is conjugated and 2 is unconjugated, we know that this baby's about to poop and pee all of it out, because it's already been processed by the liver. But if it is unconjugated, let's say we get a bilirubin of total of 7 and it's 5 is unconjugated and 2 is conjugated, we know that this liver is working really hard and is behind and is not processing this. So how do we speed this up? We can put them under phototherapy. Of course, under phototherapy, they always have eye patches on and a diaper with no other clothes on. When they're under phototherapy, the light partially converts their bilirubin from unconjugated to conjugated, which is super cool. And then we have to monitor, they can get hot under there, so we monitor their temperature. We monitor their respirations. We record I's and O's. We make sure that their urine is not getting too concentrated, because they can lose a lot of fluid from breathing quicker, from being warm under there. And then, of course, we look at the skin. When we take them out, we peek underneath those goggles and underneath the diaper and see if that is yellow compared to the skin, which should be pink. So, very important with jaundice. The nurse is assessing a 2-hour-old infant by cesarean delivery at 39 weeks gestation. Which assessment findings should be of the highest priority? So a 2-hour-old infant C-section didn't get the vaginal squeeze. We know that they're going to have extra lung fluid. So blood pressure 76/42 doesn't mean much to us. Faint heart murmur doesn't mean much to us because we have issues going on with the heart closing. So we've got the foramen ovale is closed. The ductus arteriosus is probably is open. And then, so you might be hearing a little bit of that. Blood glucose is 45, that's normal, but the respiratory rate of 76 is what worries us. Normal respirations are 30 to 60. If it is greater than 60 and a C-section, it can be transient tachypnea of the newborn. The baby is just having difficulty getting rid of that fluid and is having quick respirations, having a lot of respirations. You have to watch this real close because if they get really high, they can blow a lung. Their lung just can't work that hard, that fast, and sometimes they can have a pneumothorax. So you got to watch these kids with transient tachypnea of the newborn, and you hope this resolves within a couple of hours. A second trimester client is in lithotomy position on the examining table. That's flat on your back with your legs up in stirrups. In the obstetrician's office, she becomes short of breath, lightheaded, pale, and dizzy. What's the first nurse action? It's to turn her on her side. She should never be flat on her back. That's always a huge problem. A nurse was given an epidural opioid for a cesarean birth. The nurse noticed that the client's oxygen saturation is 92%. What action is required? So she is getting an epidural for a C-section. So she got an epidural opioid. So, you guys, this could be completely benign. She's in the position, she's hovered over probably. So what is required at this time? So we know 95 and greater is the best, but what can we do to improve this? And we see this many times. Just instruct her to take a couple deep breaths and let's see if it comes up. Usually it will. Don't need to give her O2 at 10 liters via blow-by, especially if it's just transient. Start a second IV really doesn't have a lot there. Nothing really tells you to do that. And call a rapid response. No, we wouldn't do that. True labor versus false labor. True labor is when your contractions are regular. They increase when you're walking. The intensity increases. And they get stronger. Felt in the lower back. And then they come around and wrap around the abdomen. You have bloody show because your cervix is changing, because you're dilating and effacing, and the baby's engaged in your pelvis. The baby is down low, it's putting pressure on your cervix. False labor contractions are irregular, right? They're not getting closer together. Over here, with true labor, they're getting closer together. False labor, they're all over the place. No change or decrease with walking. Contractions are felt in the abdomen and the umbilicus, which are Braxton Hicks. There's no change in your cervix, and the fetus is blottable, meaning that when you touch the head, it floats up. So the question is, when assessing to determine whether a labor has begun, what are the true signs of labor? Contractions are 2 to 3 minutes apart? No, that doesn't tell us anything. This could be hypertonic labor dysfunction. Rupture of amniotic membranes? Nope. You have to have cervical change, and you have to have a certain contraction pattern. Contractions that are felt in the abdomen over the umbilicus? No, that is false labor. And the fetus is blottable? No. The correct answer here is that contractions begin in the lower back and radiate over the entire abdomen. And of course, you'll have cervical change. A client's in the 3rd trimester of pregnancy and complains of urinary frequency. So she's got to pee all the time. She's in the 3rd trimester. This is normal. There's a baby pressing down on her bladder. The big old heavy uterus is pressing down on her bladder. The nurse instructs the client to use over-the-counter pain medication. No, absolutely not. Advise her that the provider will prescribe antibiotics. Why? This is normal. Tell her to limit her intake to 500 mils a day. Oh my God, the poor woman would be so dehydrated. That's going to be a mess. But we're going to go with the normal teaching to drink at least 2,000 mils of fluid a day. A pregnant woman at 38 weeks gestation arrives at the emergency department reporting a bright red vaginal bleeding but denying pain. Probable diagnosis. We know this one, placenta previa. The placenta is sitting on top of the cervix. It's not painful, but she's having some bleeding. Prolapse cord would be variables we would see variables, especially when the water breaks. And of course, our intervention there is to apply pressure to the presenting part, put her in Trendelenburg or knee chest position. If the cord was hanging out and they told you could put some saline on it, of course, do that. Saline soaked gauze. So those are all of those. We're going to go back to surgery. Shoulder dystocia, we know we'd have this turtle sign. We know all of our risk factors. We got a big baby, increased fundal height, gestational diabetes or diabetes in general. So we got a big baby and the head molded. Now the shoulders won't come out. So the sign during the actual shoulder dystocia would be a turtle sign. And then our interventions would be put her in McRoberts position, pull her knees all the way back, and then give suprapubic pressure. So you would press down on the shoulder to help get the baby out. Abruptio placenta is very painful. You guys, this would be major pain, and we would have a loss of contractions. Like we won't be able to see the contractions anymore. Well, that's really with a rupture, but a lot of times with an abruption, we start to see changes in the pattern because our uterus is irritated. So with abruption, we'll have pain and bleeding, and we know that it can, cause fetal death. So it can be an emergency situation. 2 IV is the whole thing. Amniotic fluid emboli. This is when usually her water breaks or at delivery. Some of the amniotic fluid can get put into the maternal circulation, and it can cause her immediate respiratory distress, or it can cause her a stroke. The nurse is assessing a boggy uterine fundus of a client who's just delivered a baby. The nurse massages the fundus and simultaneously provides pressure to the lower uterine segment. This is safety. This prevents you from pushing the uterus out of the vagina. With the boggy fundus, always we want to massage it first. Then if it's elevated above the umbilicus, we can catheter or take her to the bathroom. And then, of course, we need to monitor for our hemorrhage. So we want to, give oxytocin first. Then we can give methogen, demiprostin. We can give Cytotec, misoprostol, Hemabate, Carbapost. We can give all the meds. Those will be on the final. FYI, make sure you know your meds for the final. Of course, if all else fails, we're going to do a hysterectomy on a postpartum hemorrhage. The nurse assists the primary care provider in performing an amniotomy. So the midwife or doctor is going to break the water. In which order should the nurse perform the following? Okay, guys, obviously, assess the fetal heart tone is always first. Next, note the quality and color of the amniotic fluid, because we got to have a neonatology there for delivery if we have thick meconium, because baby may not be able to breathe. Then we're going to take the client's vitals, especially temperature, to make sure we don't get febrile. And then fourth, replace the amniotic, the soaked underpads. So here's a baby with a diaphragmatic hernia. Normally the bowels are down here. Here's the diaphragm. It keeps everything down out of the chest. You can see 2 normal lungs here. A congenital diaphragmatic hernia is when there is an abnormal diaphragm, and it allows the organs and the gut to come up and then go in the chest. It usually pushes on the lung and can cause a perf of the lung or incomplete expansion of the lung. So here is a picture of one. Here's a normal lung, and then here's one with loops of bowel all over here. So we can see that that this one, we get some decent breast sounds. But over here, what are we going to hear? Bowel sounds, because we got bowel here. So the nurse is assessing a newborn with a diagnosis of congenital diaphragmatic hernia. Which assessment should the nurse specifically expect? Of course, bowel sounds heard over the chest, because that's where the bowel is. Heard over the pelvis? No, that's where it should normally be. Absence bowel sounds? No. And faint murmurs over the abdomen? No. Okay, the nurse is assessing a woman in labor and notes the presence of accelerations on the fetal monitor. We know accelerations are always good, always good. Which of the following actions should the nurse take? Turn the patient, give O2 at 10 liters, give an IV bolus, or turn off Pitocin. No, those are the interventions for what? Late decelerations. Turn the patient? No, those are the interventions for variables. Call the provider? Number 2, this is number 2 if there was an abnormality, but this is not an abnormality. This is good. So we're just going to document the findings as normal. And here we go with our fetal monitoring. You can see that here's our contractions, and the fetal heart rate monitors or mirrors, I shouldn't say monitors, mirrors the contraction. It looks just like the contraction. So the deceleration of the fetal heart rate started before the peak of the contraction. Deceleration started before the peak. Deceleration started before the peak. So these are normal. These are good. This is head compression. No big deal. Uteroplacental insufficiency. This is when we have no reserves left. We're getting hypoxic and acidotic. So we can see here's the contraction, and the deceleration starts when? After the peak of the contraction. It starts after the peak of the contraction. And then variables are just cord compression. They always look different. They come at all different times. They have really no relationship to the contraction, and they're UV and W shape, and that is to turn the patient. A nurse is teaching a pregnant client about the expectations and complications of pregnancy and describing Braxton Hicks contractions. We all know that they need Braxton Hicks contractions. That strengthens the uterus, but we should never have more than 4 in an hour. They are very normal, but if there's more than 4 in an hour, they need to call and be evaluated for preterm labor. We never want a baby to come out early. Rhogam is prescribed for the client after delivery. Before administering the medication, the nurse reviews the client history and notes that there's a previous hypersensitivity reaction to immunoglobulin. You would not give it in that case. If the patient is O negative, yeah, that's okay to give it to her. If the neonate is A negative, we would not give it. We don't need to give it. But this is the big one, is that you're going to hold it if there's a previous hypersensitivity. A nurse is monitoring a patient with a placental abruption. We know that this is really, really bad. We need 2 IVs. We need to get saline up. We need to have continuous fetal monitoring. We're in big trouble. Which pattern of the fetal monitor indicates that to the nurse that the fetal tissue perfusion is adequate? So how do we know that the baby is getting enough oxygen? There's normal fetal heart tones. Mom's maternal pulse ox is going to tell us half the story. And these are not normal fetal heart tones, 130 to 180. 110 to 160 is what is normal. A nurse is performing an assessment of a female with suspected middle schmerz pain. We know this is when the ovary actually ejects the ovum and goes into the tube, and it's actually a physical tear. Which question is specific to elicit more information? Do you have sharp pain in the right or left side of your chest? No, your ovary's not in your chest. Do you have sharp pain on the right or left side of your pelvis during pregnancy? No, this doesn't happen during pregnancy. This is when you're ovulating. Do you have sharp pain on the right or left side of your leg? No, your ovary is not in your leg. Do you have sharp pain on the right or left side of your pelvis? Yes, absolutely. And this is prior to pregnancy. A nurse is reviewing a neonate for early discharge. Which of the following, if noted in the infant, would indicate that the criteria has been met? It's all of these. Vital signs are normal. Baby's urinating. Baby's passed stool. It's completed a successful feeding. Everything is good, so we could do an early discharge. A client, pregnant client with sepsis, oh, terrible, is monitored for signs of DIC. Which of the following labs make the nurse suspect DIC? Increased platelets? No. Decreased platelets. Increased D-dimer? No. Increased D-dimer. Decreased schistocytes? No. Usually increased schistocytes. And I'll show you. But increased fibrin degradation products? Yeah, dudes, they're throwing out everything they got. So in early DIC, you're going to get clots all over the place, and then once they're all gone, then the patient's going to bleed out everywhere. Here's a little diagram. So you have the disorder associated with it. Usually ours is HELP syndrome, and then they go into DIC, but this could be sepsis. Activates coagulation, so you get widespread fibrin deposits. You use up all the platelets and coag factors. You have little tiny clots. And then once these little tiny clots go into the organs, it creates organ failure. Then you have no platelets left and no coag, so you have no fibrin, and then you're going to bleed out. And then here is our last one, just some labs that change in DIC. Platelets go down, fibrinogen goes down, proton goes down, prolonged prothrombin time, antithrombin goes down, and then fibrin degradation products go up. And then, of course, the D-dimer goes up. Now, I just want to show you one more thing about these hints for the NGN questions. Hold on one second. Let me just pull my book up for you and go through a couple of things. Let me pause. Okay, guys, so I want to go over this chart real quick. This is on page 380 of your textbook. 380 of your textbook. And it is the Maternal Fetal Triage Index. And so it talks about their level of triage and what we need to do for assessment. So I want you to go to page 380 and look at this, look at it, because it's harder to read on here. But if the woman presents with no complaint, then we're good. But if the woman presents with a fetus that is a stat 1 priority, or the fetus requires immediate intervention, life-saving interventions, or birth is imminent, they're a stat 1 priority. You can look at the box on the right and look at the abnormal vital signs. Immediate life-saving interventions required. Fetal, like a prolapsed cord, says imminent birth. Obviously, we need to get to her. A stat 2 is, or an urgent, or priority 2 is a woman in severe pain without complaint of contraction? Is it a high-risk situation? Or will the woman and or newborn require higher levels of care? So you can look over there, again, abnormal vital signs, severe pain. Examples of the high-risk situation: unstable medical conditions, suicide ideations, homicidal, altered mental status, vaginal bleeding. And then we can see here, if it's greater than 34 weeks, we have some risk, and then we need to transfer care. A priority 3, or prompt, is she have a change in vital signs, or does she require prompt attention? So again, abnormal vital signs, signs of active labor when she's term, leaking of fluid, contractions, HSV lesions, which we know is a C-section with regular contractions, and we can look at that. Okay, non-urgent, or priority 4, does she have a complaint that's not urgent? So she's 37 weeks, greater than 37 weeks, so she's term and her water broke. Has urgent symptoms that include common discomforts of pregnancy. Or number 5, schedule. We're just going to schedule her because she's not a huge priority. Woman requests a service and has no complaint. This is just for prescription refill, outpatient services, and such. So this is a great chart. I want you to look at that on page 380 of your text. Okay, now I want you to look at some cues, some clues, some prioritized clues, and then some solutions. So of course this is ADPI assessment. So we're looking at recognizing clues, analyzing clues, and planning would be analyzing the clues and prioritizing the clues. And then interventions would be the solutions. So in stage 1 of labor, look and see if she's contracting. Note the frequency, duration, rule out hypotonic or hypertonic labor. Assess the cervical dilation and the station. Review the mom's birth plan. Let's make sure we're doing the things she likes as long as it's medically indicated, and think about her plan for management of pain and analgesia and anesthesia. Now let's analyze the clues. Determine if the mother can manage pain without medicine. Of course, breathing. We're going to show her breathing patterns, relaxation, activity with contractions. We can tell her to breathe or however she likes to handle it, and request for pain medicine. Identify the effectiveness of the support person during the contractions. So we need to make sure she has support. Again, they're very strong about that in this new book. Assess the vital signs. Look at the fetal monitoring. Make sure the heart rate is fine. We want to make sure that there's either earlies, and we want a reactive NST, or if she's not contracting, a reactive NST, or we want accelerations. Earlies are fine. We really don't want any lates. And of course, if there's variables, we'll change position. Prioritize clues. Note any irregular BP. We really worry about that, especially with anesthesia, epidural anesthesia, respirations or temperature. Dizziness, tingling of the fingers, obviously is respiratory alkalosis or hyperventilation, and we would have her cup her hands to her mouth and deep breathe in her cupped hands to decrease this. Acute escalation of pain symptoms, really we worry about abruption. Like, is it getting really bad? Is it breaking through the epidural? Or is it just delivery? Because it will have a lot of pressure, a lot of pain, and so you want to check her cervix. Report any changes in fetal heart tones. Report any stalling of labor progress to the obstetric provider, because we might be in a hypotonic labor pattern. Or we might have cephalopelvic disproportion where the baby is too big to come out. Report any change in maternal pain tolerance, unable to relax, hyperventilation, verbal report of pain requests and pain management. Is she, what's happening? Note any unusual vaginal bleeding, change in fetal position, or cord prolapse. Yes. So solutions, the interventions, review the birth plan. If mother and the fetus are stable, the mother desires unmedicated birth. Absolutely. We want to do what she wants to do. Consider optional pain management options. If she doesn't want any analgesia or anesthesia, she can walk, position change, breathe, use the tub. We love that, or water. Non-medication pain options, like massage, deep breathing, relaxation, TENS unit, acupuncture, acupressure. Assist the support person with coaching during delivery, and if the mother wishes to explore analgesia or anesthesia, discuss the options. So here is the guide for the third stage of labor. So remember, in the second stage of labor, the baby was born. Now, this is a very, very scary time that the third stage of labor, when the placenta is delivered, that we can have a lot of problems. So recognize the cues after delivery of the fetus. So look for vaginal bleeding, abdominal cramping, umbilical cord length, and consistency of the uterus. The umbilical cord lengthening, the uterus elevating, the abdomen coming up, and a little splash of blood when the placenta separates are all normal. But we're going to look and try to see if we see anything abnormal. Determine where the cramping is located and verify a constitution of pain. Cramping is typically the return of moderate and strong contractions to facilitate the placental expulsion. Yeah, so they're kind of like all in their feels with their baby. So many times they don't feel this, but they may feel a cramping. Determine the amount of vaginal bleeding present, trickle or gushing. It should not. So while we're waiting on the placenta, we should not have a trickle or a gush. When the placenta actually separates, we can see some blood discharge because, of course, blood is coming out of the placenta because that's baby's blood. But we should never see a trickle. Verify lengthening of the umbilical cord, which is normal. Verify consistency of the uterus. We want a firm uterus. We want it to contract. And of course, we're going to give that oxytocin bolus after this. Prioritize it. So determine risk factors for retained placenta. So of course, we're looking for an accreta. Anything that could tell us that, there was scarring in the uterus before this, if they ever had any surgeries, anything at all like this could mean a retained placenta, which is terrible. You can look at the ultrasound report too and see if you see any satellite pieces. Determine if it's been longer than 15 minutes since delivery of the fetus. They've changed this. We've always said 20 to 30, and now this is saying 15. Verify normalcy of the third stage bleeding pattern, estimate blood loss, and concern for immediate postpartum hemorrhage. So you guys, if we see that she's bleeding a lot, we got to start worrying about a retained placenta. We might have to take her back for surgery to get it off if it's an accreta, increta, or procreta. Or if there's a satellite lesion and we can't get it off. Or we have retained placental fragments in there that we can't get off. How we know it's normal, verify lengthening of the cord as it descends into the introitus and the placenta is coming out, and look for changes in vital signs. Of course, teach the solutions or interventions, teach the client about expectations of the placenta. We want it to come out in one piece. Be prepared for potential complications, retained placenta, immediate postpartum hemorrhage. If it doesn't come out or we don't get it all out, assess vital signs every 15 minutes for maternal stabilities. Of course, we're looking for that widened pulse pressure, followed by tachycardia, followed by narrowed blood pressure, and then, of course, assess for early signs of placental separations, again, which is lengthening of the cord, rise in the abdomen, and a little gush of blood. Assist the mother to push. So what does that mean? You just tell the mom to push when the cord lengthens. Then actions, monitor blood loss, of course. And again, if it is if we're in an ideal situation, we're going to be weighing everything to make sure that we don't have too much blood loss. Provide fundal massage as soon as the placenta is expelled to get nice firm contraction, stop the bleeding, give the oxytocin, which is usually a bolus, and order and assist with contraction to prevent hemorrhage. So you would help with the fundal massage or whatever they needed you to do, get the medicines. So you guys, this is the clinical judgment at the 4th stage of labor, and this is during stabilization of bleeding. And we want to look for perinatal or parental attachment after birth. So the cues, the mother and the support person are holding the baby, looking at the baby, say, oh, it looks like me or you, counting the fingers and toes, commenting on it, calling the baby by its name. These are all good attachment issues. Of course, in the first 30 minutes, we want the baby to feed in the first period of transition or reactivity. Analyze the clues, look for any circumstances that might prevent this, like if they had a C-section or the baby went to the NI or mom was having a hemorrhage. This can cause delay in bonding. Mother and infant are stable, no skin-to-skin contact. We definitely want skin-to-skin. Dry the baby off, then put the baby up to the chest, and if she wants to breastfeed, she can. Note verbal expressions of exhaustion by the mom, physical inability to hold her neonate. So if she's just like physically tired and cannot, understand that that is not an issue. That is just she's tired. Note engagement of the support person or other parent. Note the ability to comfort a crying baby. So if you see that, you know that she's in tune with her baby. Note cultural considerations. Some may not be congruent with standard practices of Anglo culture, which is so true. Like, just different ones. And we have, if you look up in your book, cultural, we have so much to cover in this class, but if you look up cultural differences, you'll see that some, hand the baby off to the mom, and, it can be just normal for the culture. Prioritize clues. Determine if you need to manage unstable vital signs. Yes, don't let the mom die. Unusual vaginal bleeding. Address pain. Determine if the newborn needs interventions. Suction, mouth and nose, and swaddling. Note any physical concerns that would prohibit early attachment. If mom feels scared to hold him because the IV is blocking her arm, or the blood pressure cuff is going off, or whatever, try to fix that. Determine the need to model early attachment behaviors. So you guys, when they hold their finger and talk to them, all those. Solutions: assess the mom's comfort level by caring for the newborn. Maybe she doesn't know, so try to help her. Encourage skin to skin, breastfeeding. Teach them about newborn behavior, early behavior. They cry a lot. Demonstrate newborn care, diapering, umbilical cord care, bathing. This is usually after the first couple of hours. Discuss demonstration of newborn comfort techniques, swaddling, talking, rocking. Assist with feeding, position, burping, latching, and newborn behaviors. And of course, rooming in. Okay, now I want to talk to you about clinical judgment for mastitis in the breastfeeding mother. Recognize clues of mastitis, like, of course, her breastfeeding method, breastfeeding or non-breastfeeding. So we need to know that before we can look at what the cause is. Number of days postpartum usually occurs in 2 to 4 weeks. Breast pain, area of redness, warmth, sudden onset of flu-like symptoms, fever, chill, malaise, body aches, nausea, and vomiting. We know all of these. Analyze them. Is there breast pain? It's usually in the unilateral in the upper outer quadrant. Assess the vital signs, especially the temperature. She could be really sick because she's got an infection. Look for enlargement. Axillary lymphadenopathy means the infection, the lymph nodes are trapping it. Look for cracks or red nipples. That's how the bacteria got in and created this infection. Observe for the integrity of the breast tissue. Look for abscesses, open areas, warmth, redness. Determine the breastfeeding episodes. How often is she breastfeeding? Because you guys, she can get super behind here and the baby can lose weight. Determine if the mother is still able to breastfeed or if she's pumping. Look at the clues. Determine for any surgical interventions requiring IND or aspiration. This would be really late. Determine if the newborn is receiving adequate uninterrupted nutrition. They should try to breastfeed through mastitis. Most of the time they can, but if they can't, then we need to look at supplementation. Solutions, teach the clients about mastitis before discharge, because the earlier we get on it and give an antibiotic, the better off we are. Encourage prevention strategies. Okay, here's one for clinical judgment for pathologic jaundice. We know pathologic jaundice is a bilirubin greater than 5 in the first 24 hours. We really worry about that. Or if it's a grade increase and the transserum bilirubin is greater than the 95th percentile when we look at it on the bilirubin nomogram. Okay, so analyze clues, review the maternal history like RH incompatibility, ABO, or other hemolytic disease, G6PD can cause it, prematurity, sepsis, maternal diabetes, risk factors, Native American or Asian race, birth trauma, vacuum, forceps, cephalohematoma, or a previous sibling who received phototherapy. Monitor the serum bilirubin levels daily. So if it's pathologic, dudes, we're going to have to do straight away blood draws and not transcutaneous levels. We're going to do diagnostic blood draws. Review the other labs, the Coombs test. Of course, if that's positive, we know we're going to have trouble. It's also called the direct antigen test. It goes from +1 to +4. +1 is we're going to have trouble. We're going to have some jaundice. +4 is we're going to have overwhelming jaundice. Reticular count site can be high, and then the crit. Of course, we can watch it fall because of the lysis of the red blood cells. Monitor urine and stools. Document visual assessments of jaundice. We've talked about that earlier. Observe and document changes in the infant behavior because they can get lethargic. Prioritize clues, look at the time that it happened. So again, before 24 hours is critical. And we know that we don't want unconjugated, untreated bilirubin because it can cause brain damage. So acute bilirubin encephalopathy with lethargy, hypotonia, irritability, and seizures and coma is, untreated, unconjugated bilirubin can icterus irreversible long-term consequences of bilirubin toxicity. So you guys, they have permanent brain damage. Solutions, encourage feedings. Feed. The more you pee, the more you poo, the more bilirubin slides out the chute. Assess for factors prior to delivery so that we know we got to keep a close eye on this kid. Closely observe the infant in the first 24 hours for signs of jaundice. Teach the parent about differences between physiologic and pathologic. Actions treatment will depend on the level, the gestational age, and the presence of risk factors. The goal is to reduce it and not have unconjugated bilirubin. So we can do phototherapy. And then of course exchange infusion. If all the red blood cells are lysed, this baby might need some blood, and we might have to give the baby blood because everything is lysed open. Teach parents of the importance of following up care and clear discharge instructions, and then evaluate the overall status of the newborn. We'll look at the bilirubin levels, make sure they keep going down. Early identification and treatment will prevent acute bilirubin encephalopathy and connectorus.